Good afternoon, good evening to those of our attendees who are in India. Welcome to this webinar. This is the first ever webinar being organized by the Indian Fertility Society's United Kingdom Forum. So this is a major new event for us as a new forum, a new organ of the Indian Fertility Society. I'm delighted that we're able to organize this, and you're all very welcome to what I hope will be a really informative and enjoyable afternoon. I will not hold up proceedings for very long, but I would like to take the opportunity to extend a very special warm welcome to Dr. Pankaj Talwar, who is the president of the Indian Fertility Society and who has very kindly agreed to join us despite having an extremely busy schedule in Delhi. Everybody knows Dr. Talwar very well. Apart from his role leading reproductive medicine in India, he's also very active in his clinical work and in his training and research. He's a commissioning editor of Fertility and Sterility, I believe, and very impressively, he's a recipient of the Vishishta Seva Medal, which the President of India gave him for his services to fertility. So we're honored to have you with us, Dr. Pankaj, and I would be very grateful if you would say a few words as an introduction. Thank you.
Thank you so much, Dr. Raj, and I bring you greeting from Indian Fertility Society in India. And it's a very big day for me today. And I think I'm the person chosen by the Lord Almighty to be talking to you today. I'm privileged. We had this forum made after a long time of deliberation in month of August, and I think we are on the third month of our collaboration. We have named it United Kingdom IFS Forum. And I think it's a very special forum for us. And same day, we had a launch of two forums. That is a New Delhi Forum and United Kingdom Forum. So the day always will be etched in our memories. So as you all know that we have our patron, Dr. Jayant Mehta, present here. Very good evening to you, sir. We have Dr. Raj Mathur, our Secretary General. Dr. Harish is our Joint Secretary, and Uma is our Treasurer. And we were such lovely people present here today, Dr. Gulam. I think we've been reading about from your articles, sir. Your work on IUI has been very encouraging, and we always quote you in all our studies, in all our presentations. We have Dr. Priya speaking on add-ons on IUI. Then we have Dr. Priya talking to us on PCOS. So I think something about our society. We had a very humble beginning 20 years back in New Delhi with barely 18 members. And after 20 years now, we are 4,700 member strong society in the India and pan world. We have got, at this point of time, 29 state chapters. So we've got 29 bodies like UK Forum. We've got 29 chapters all over the country, and which are governed by executives like we have in the UK Forum. We've got more than 20 special interest group, which are leading different parts of research and collaboration in terms of, say, endoscopy, it can be genetics and multiple other things. I'm very sure that when we all come together, the United Kingdom and Indian Fertility Society, I'm very sure that it'll be very collaborative and research-oriented association. And we are grateful to all of you, sirs, for helping us out in creating this wonderful little baby. I'm sure that we'll all be there to see it rolling as a teenager and as an adult. So, Dr. Jayant, Dr. Raj, Dr. Harish, Dr. Uma, I welcome you again from IFS New Delhi to be part of us. And I'm very sure that we'll all work together for a very long time. So with this, I'll hand over the mic back to you, Raj. And greetings to all of you present across the screen from United Kingdom and India. Thank you so much. Jai Hind.
Jai.
Jai Hind. Thank you very much, Dr. Pankaj, for those very warm and characteristically humble and simple words. Thank you so much. You're really an inspiration. It is now my very pleasant duty to introduce our chairs for this afternoon's webinar. And I'm delighted that we have two doctors who are both office bearers in the IFS UK Forum, Dr. Harish Bhandari and Dr. Uma Gordon. Both Harish and Uma are old colleagues of mine in various aspects in fertility in the United Kingdom. They're both subspecialty trained in reproductive medicine and surgery. Harish is a consultant in Leeds, and Uma runs a service in Bristol. Um, I'm sure you will see quite a lot of them, and I'm delighted that they're also attending the Fertivision conference where they will be contributing. So now I hand over to Harish and Uma to take the program forward. Thank you.
Thank you, Raj, for your kind words. It's my pleasure to welcome everyone as well, especially on a Saturday making time. But it is a very interesting and worthwhile webinar to attend. So my pleasure to introduce Ghulam here. He's a good friend. He's also a consultant clinical andrologist at North Middlesex University Hospital. Many of you will know Ghulam through his publications and talks on male infertility. He has led research studies and publications on preservation of male infertility, and in particular, IUI. He believes in it, and he has been instrumental in improving the success rates at the North Middlesex University Hospital, and he actually collaborates with other clinics to improve their success rates. And he has also engaged with NICE, which is the National Institute of Health and Care Excellence in UK. So Ghulam, looking forward to your talk on IUI Back to the Future. Thank you.
Raj, and the organizing committee, I'm grateful for this invite and also to accord me one of the three positions of the inaugural speakers today. It's Back to the Future with IUI, and I'll be talking about expanding fertility options, improving outcomes, and enhancing global treatment. In order to do that, I need to cover, let me just go for the big screen share. Yeah. Okay. In order to do that, I need to lean on the historical perspective of practices, the factors that influence the practices, the economics of IUI and IVF, the political influences on stakeholders. What do patients really, really want? The safety of patients and the offspring, what needs improving, and how are we going to project for the future? At the end of my talk, I'll be telling you that IUI can match IVF success. IUI baby significantly is more cost effective than IVF baby, and we need to focus on improving IUI success rates. In terms of evidence base, the IUI practice is grossly distorted by IVF practices to really look into the true practices. But hey, we need to move on because IVF and ICSI were not based on evidence based medicine. You are the expert. Do what is right and put safety of your patients first and optimize the success rates. Aim for the reduction in multiple births, individualized treatment, especially from the third cycle onwards. Think outside the box. The tools that you have that you need are on the right-hand side, and it's aimed for a bifollicular environment. Use gonadotrophin stimulation, and preferably, if you can, in combination. I would suggest avoid clomiphene, and I'm sure that that will come through in my talk later on. Male factor is a very important thing. I've given you the concept of consecutive ejaculation, and we need to follow that one through. It's a scope for double IUI, and don't be afraid of unilateral tubal blockage. IUI is not inferior to IVF, and we need to begin thinking in terms of global accessibility to the wider patient groups. I'd also want the future to look more into the male focus. And at the bottom, where I can't see what appears, is I think there's scope to look at future avenues of AI and other aspects. Now, when we look at the economics and is that the global market size in 2023 was 34 billion, and it's projected to 62 billion in 2033, and there's global inequalities. Remember, IVF success rates back in 1991 were 6% per embryo transfer, and in 2019 it's about 25% per embryo transfer. And at the end of receiving treatment, about 75% of the women after IVF still remain barren. In terms of funding models, for instance, in Netherlands, everything's publicly funded, so there's no add-ons. In Spain, most of the practices are on ICSI. In the UK, it's over 60% of the IVF treatments are self-funded, and that causes a lot of financial, emotional strain for patients. So I just want to have a look at the Spanish one because that's quite interesting for me. Because before and after legislation, if you look at the red box, you'll find that after legislation, that's a third column, is that 85% of all the cycles are having more than two embryo transfers. And if you look in the green box far below, is that the multiple birth rates are very, very high, unfortunately. And so ICSI being practiced willy-nilly, there is absolutely no benefit whatsoever, and it should be considered as an add-on. Sorry, Priya, I'm taking your one word out of your lecture. Now, why is it a problem that I see? Is that because if you look at major birth defects after 12 months, and particularly we should be looking at 5 years analysis, but here we have five, is that natural conception versus the ICSI IVF. Is that this discrepancy is that every intervention that you make in IVF process increases the risks. That means any departure from the natural process will add to the adverse outcomes. IVF singletons have higher risks, and that overall IVF ICSI pregnancies carry a twofold higher risk of preterm births. Now, if you use frozen embryo transfer, they're larger babies. If you do IVF, they're greater male births. If you do ICSI, they're greater female births. If you go for day 5 blastocysts, you get more female birth. So you can see that altering the system will alter the destiny of the offspring. And here's the graph that shows the sex ratios between ICSI at the lower end and and the green one being the IVF end. So what do patients really, really want? The most visited website on the HFEA is the IUI page, would you believe it? That is the most visited website. So therefore, what happens to IUI will be dictated by what happens in IVF. And unfortunately, commercialization and the distorted success stories and the advanced technologies actually give perhaps a biased picture of what is happening. In all this, the male factor investigation is lost. Treat the man, not the sperm. And I think I'm going to give a talk tomorrow on just male factor fertility, and I'm going to expand on this terribly much. And I have some ideas on where to make the improvements. So there are ethical concerns overall, and that unfortunately and I know from practices that IUI sometimes use in IVF clinic to manage the success rates of the IVF, in which case it creates a bias towards having lowered success rates. And I'll show that one example in the next slide, and there are not many published data on that one. Now, as Uma kindly mentioned about NICE guidelines, the question that I asked was treat with 35 milligram clomiphene and IUI and compare it against expected management. What's the difference? There was no benefit in IUI, and they recommended do not practice IUI, but instead practice IVF. Well, that's not evidence-based medicine. This is a case where poor responders uh, uh, are being pushed on to recommended to do IUI. And so this is what I mean, that there is an element of bias that is created, which is suppressing the success rates in IUI. Now, if I tell you where does IUI success rates do really fall, I think consistently at our clinic at North Middlesex, a third of the women entering our program, every 100, we're going to get 33 of them pregnant. And against what it means against the HFA database, you can see that this is what is achievable if you try for it. Now, there are many algorithms as to when and when not to treat for IUI. I'm going to cut right across all that and be brave and say in all cases, except bilateral tubal blockage and severe male factor, try and aim for IUI. Let's just turn to sperm. The more abnormalities there are in sperm, the greater is the infertility. Just to look at the box on the right-hand side. Now, there are colleagues who are on this in the audience who have helped me publish this paper. Um, and the question is, how many IUI and IVF cycles are equivalent? Broadly speaking, it's 3 to 1, and in extreme cases, it's 7 to 1 on the right-hand side top. In our study, it was 2.35 IUI against 1 cycle of IVF as practice. And if you came to our clinic at North Mid, it's 1.7 to 1. Now, look at the right hand, the green box here. How different is that? If you were to compare the mid-cycle IVF against an upper IVF, the ratio is 2.2 to 1. You can't really say you cannot submit mid-performing IVF should not be practicing. The question is, how many IVF cycles do we need to realistically achieve a pregnancy? It's 3.7, according to our study, and 8.7 as practiced on IUI cycle. And if you came to our clinic, it's 6.4 cycle. And I think we have improved a lot more on that. And one of the other issues that we calculated was the neonatal cost to the National Health Service, and I did not even factor in all the other costs that went into freezing and all that. So here's a cost-effective analysis that we do as practice. Is that it was £42,000 cheaper to get an IUI baby compared to IVF baby for the period of study. And if you came to our clinic, it was £76,000 cheaper to achieve the same thing. So if we look at the as practice against what we did, is that what does IVF need to achieve a cross-neutral position? And as practice of 12.1, IVF would need to deliver 32.5% per embryo transfer to get cost neutrality. And if you were to come to our clinic, it would be 42%, which is, I think, virtually not easy for IVF clinics to do. So there's merit in what you call uh, investing in improving the success rates of IUI. And here is a very big study on IUI IVF in ovarian stimulation for unexplained. It clearly shows that women with unexplained infertility, there's no significant difference in the effectiveness or safety outcomes between those two regimes. And there's no evidence that IVF reduces the time to pregnancy leading to a live birth compared to IUI with ovarian stimulation. The question that often arises is how many cycles of IUI do we do? Well, 6 is what I would have said, but here's a published one at 8. But what you can clearly see that even with 8, the cumulative success rates are improving. So how much sperm are we going to put in terms of IUI? Most of you think it's between 2 and 5, and you're not wrong. But look, if you were to go beyond the 5 million threshold, look at how the success rates are improving quite significantly now. And performing the same analysis by breaking down the age of the women, this pattern is retained. It is robust. Another study shows more or less the same thing, again, with 5 million, um, you're getting a success rate, but if you go towards the 9 million mark, then clearly the success rates are very significant. And that's also not to say that anything less than 1 million you can achieve pregnancy, but you need to change your strategy here. And the key factors here, the cycle number, the age, and the protocol, the FSH protocol, that becomes quite crucial. And for this reason, I feel very sorry for single and lesbian women because the amount of sperm that they're actually being given, they don't need to reach 6 cycles to achieve their success rates. If we could only deliver a bit more, give them what we call uh, uh, what I would say an honest amount of sperm in the first insemination. So let's turn our attention to the stimulation protocol. Clearly, the follicle stimulating hormone is significantly better than clomiphene, uh, and this is also seen in other studies here. That the HMG-IUI is far superior than the clomiphene. And by the way, forget natural IUI cycles; they simply don't work. Now, let's turn our attention to if we were to improve the number of follicles. So in the letrozole and gonadotrophin group in the purple box, you can see a very significant increase in the success rate. But don't lose sight of what happens to clomiphene. That's a line just above the purple line. There is no increase in the success rate there. So the multifollicular environment, going from 1 to 2, there's a significant increase. And the last line here, there's a statistical modeling where going from bifollicular IUI potentially increases the pregnancy rate 3.4-fold. I have yet to see this being translated. Now, there may be merit in the use of combination stimulation protocol or sequential protocols, but for brevity of time, I'm going to skip that for the moment. Suffice it to say that the clomiphene and HMG group versus the letrozole and the HMG group, the second one, the success rate's a lot better. And in the Allegro study, the gonadotrophin came well above clomiphene and letrozole. So this, I'm just relaying as I read it here. I want to turn my attention to to the male factor. Can we alter the destiny here? And indeed, you can. Consecutive ejaculate profiling is something I've done practically since 1985, but never published it till much later, maybe 2015, I think. Uh, but the second ejaculate is actually worth looking at. There's a rapid motility is much better in the second ejaculate, and if you were to put it through CASA, you'll find all the linear in the green box parameters are so much more superior than the first one, and that the DNA fragmentation in the short abstinence is much less. And if we're to look at the pregnancy rates in terms of ejaculatory abstinence, clearly anything 2.5 days and earlier will actually, or to the left-hand side, will certainly help improve your success rates. The DFI is certainly that the DNA fragmentation is correlated with the abstinence period, and that the DNA fragmentation is also correlated to the progressive motility, and you can see that the odds ratio are very significant on both of them. What else can we do? We can actually alter the destiny of the sperm behavior if we did a split ejaculate. Um, that's purely because you're going to change the biochemistry of the ejaculate, and this gives a chance for the sperm to function in a slightly different way. Uh, sorry. So I'm going to turn our attention to something that's more important for you guys, the clinicians, is the enigma of timing. And this is of paramount importance. One thing to bear in mind is the HMG and the clomiphene, the optimal follicle size for a trigger are different. And that and this is quite, and that the insemination after that also becomes quite crucial. And in the last line, it was 29 hours that we found optimal, and I helped another clinic, and they achieved more or less the same thing. And the most problematic one that in terms of results, we found that it's the Monday inseminations actually yielded the worst results for us. So that tells us we're not managing our weekends very well. But look, if you increase the number of inseminations, then you will then the chance of conception will increase. Most of the inseminations in this study are done between 33 and 39 hours. Um, am I repeating myself here? Uh, yeah. And so i- if you were to do a single insemination between 36 or 24 hours, most of the pregnancies will actually be in the 36-hour mark rather than the 24-hour. But what we also need to bear in mind that in clinics like ours, we have ethnic differences, and we need to start thinking about what we could be doing here. We published on single and double IUI with Roy Homburg, and clearly we feel that there is although the data is weak, that the double insemination may be beneficial, but there are other studies which don't come in this meta-analysis, is that they're clearly showing much greater success rates on the double versus a single. And but there are certain areas that we need to look at, and that is ovulation dysfunction, male factor, and ovulation protocols, where the double one will be better. The ovulation protocols, the clomiphene ones, don't fare well. The gonadotrophins do. Uh, and below this line, I'll just show you that the benefit of using double insemination would increase the pregnancy rates and certainly male factor infertility. Unilateral blockages, don't be afraid. It just so happens that the success rates are just half, but you may have strategies such as increasing the number of follicles on that one. In terms of progesterone luteal support, there's absolutely no benefit in the clomiphene-induced cycles, whereas gonadotrophin, there is a significant benefit. Now, of course, this is a debatable area still. So let me just now turn my attention to the endometrium. Anything above 8 to 12 is what is good, but is endometrial thickness alone the answers? I think deeper individuals will be thinking in terms of VEGF, interleukins, and integrins, but then there are people like myself who are thinking about sperm-borne factors, quality of sperm, DNA, RNA, and cofactors that may help implantation. And so the future that I see is that we need to be working on the role of the sperm and male factor. And I say this because if you look at infertile and fertile males, the RNA IGF-2, for instance, there's a lot of it in the fertile group, but then in the infertile group, and that dictates whether the embryo will go to a good maturation state. In fact, this can also be used as a predictor of whether the embryo will go to blastocyst day 5, believe you me. Okay, that's saying the same thing in another study. It's between 10 and 14 is the optimal size for a success. Um, and you have to bear in mind that the endometrial thickness, the clomiphene and the gonadotrophin will be different. I have very little information on the letrozole group, but I'm looking at overall low to moderate data quality. And that the live birth associated with peak serum estradiol level in letrozole cycles is that delaying the HCG trigger till the E2 level increases after aromatase inhibition um, may well improve the pregnancy rate. Don't ask me any questions on that because I've just bunged that in the last half an hour. And that there's a significant drop in estradiol concentrations over ovulation trigger, which are associated uh, with IUI treatment failures here. So there are other strategies. Bed rest, I hardly need to mention bed rest here. But there's another one that another clinic that I've been helping. They've been using aspirin but this is not our data, that's their data, but sorry, not even their data, that's data from somewhere else, is that look at the aspirin and non-aspirin group. There's a very significant difference. So we need to be looking at all this. Having said all this, do you realize that your laboratory is the most important part? They could win or lose that whole game for you. And I think we need, I could drill into the various details of what needs to be done, but this is not, I'll have to cut short my time. So coming back, I'm not going to regurgitate all what I have said. You are the boss, you are the expert. Minimize the risks on OHSs and multiple births, but be innovative. Think outside the box. You've got the tools on the right-hand side. Please use them. So I'm going to perhaps not end up on a perhaps more moral basis, uh, 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 and say that. So where does this leave IVF? It will not affect the number of cycles of IVF that the world will do. What we need to do is release the money so that women who need more cycles of IVF, remember I said 3.7 cycle? Well, women who need more cycles will actually need a lot more cycles. And we have a moral duty to ensure that these women are now been given the chance to have more cycles of IVF. Um, and thank you all, and I hope that you can take my message. I hope there is something in it for every one of us here to think about. Thank you.
Thank you very much, Gulam, for that great overview on IUI and giving us some tips about how we can improve success rates. We have a very good question here from Dr. Lakshmi Shingashetty. You mentioned that in the fertility sterility paper, 8.6 IUI cycles are needed versus in your own clinic, 6.4. And she raises the question, is this the same across all age groups? So I'll read her question because she puts it very well. In regard to the number of IUI cycles offered to a couple, would it remain the same across the different age groups, i.e. 6, 8 is the numbers you've quoted?
That's a very good question. We don't we we don't have enough data to break it down, firstly, into the age bands. What I had done, I mean, our study actually was from a freedom of information request. And when I put my clinic data in, I had to abide by the same rules for that period. Because in that time, our success rates were no longer 15%, they were actually 18 to 20%. And I couldn't fudge the figures because, and I have two people in the audience who are part of the study, who and they've been absolutely been critical about how. So the answer to your question is no, we haven't broken it down to age, but look, it makes sense. The more attempts you make to make it successful, the fewer the cycles will be. That was the key message, wasn't it? From 8.7 to what we could do, we needed far fewer, and now we need even fewer cycles. So there is room to invest in IUI success rates overall. And for older women, now I'll tell you something, because this is not my clinic, a clinic that I've been helping. I've been banging on to this great clinical lead. She's an English lady, and we had real battles on everything, but in a nice way, what she said. And then finally she succumbed and she started doing the combination treatment. And in the over 37 group, I couldn't believe when I saw the results. It was gonadotropin and clomiphene. And of the 86 cycles they did in this over 37 group, the success rate was 24% per cycle. But again, it's low numbers, and I'm astonished. So if you're prepared to be adventurous and think outside the box, even for the older group, you can begin altering your protocols and achieve higher success rates. So there's no uniform protocol. I think it's okay to have a uniform protocol maybe for the first two cycles, but in our clinic, what I'm doing with every cycle, I'm sitting down with a nurse and saying, where did we go wrong? You know, and see what we can do to alter the destiny next time. And we make strict notes. Even the abstinence, we have to begin educating the patients, the male patient, that this is what is good for us in this next time. And so we are actually scouting ahead so that in their mind, they are not, they know that we are together in our strategy. But thank you. That's a good question. Well, I hope we can get more data.
Thank you. Thank you, Gulam. From Raj here, Raj Mathur. Would you manage IUI for same-sex couples and single women differently from IUI for male factor infertility in terms of ovarian stimulation, number of inseminations? Would you do it differently?
Okay. Thank you, Raj. This is a very important question. I feel very sorry for the single and same-sex couples because um, in the mid 80s, I ran what we call the Middlesex Hospital, and had the largest donor banks in the country. And later on, it's me who started the London Sperm Bank with Kamal, um, because he invited me to rebuild that. But we, in that time, were getting cumulative success rates of over 75%. And that is because we're inseminating, we're doing two double inseminations using 1 milliliter of semen. What are women being provided with? Let's think about it again. In natural intercourse, there's literally 2 to 4 milliliters of semen being deposited. What are these women getting? What we used to do was quite reasonable, and this is in the mid 80s, we're getting that success rate, and that's not even, and the first three cycles were not even stimulated. We only stimulated them after. So these women should not even have to go through all that. They need to have a fighting chance, and the success rates can be quite good. That's why I threw that slide in just to remind myself that they're not getting enough sperm. When you buy the frozen sperm, it's 0.7 mil. Half of it is semen. After freezing and thawing, you've even lost more of it. You're not delivering sperm, really. You're not delivering enough sperm to give them a fighting chance. I wish I could fight for them really and open up another avenue. Thank you, Raj.
Thank you. Thank you, Gulam. Shantanu, of course, is focusing on the UK side and is saying what can be done to improve IUI funding in the NHS. A very short answer on that, please, Gulam, in the interest of time.
I have been fighting for IUI funding, and at our clinic, we did get funding. It's a question of persuading your ICBs. Thank you.
Thank you. Thank you. Can I just ask one last question and then we close this? With the numbers that you have quoted, you need maybe 6 to 7 cycles or 8 cycles. Have you included the cancel cycles?
This is data from the Freedom of Information data from the HFA. We had to do that because I did not want to be accused of any bias in this. And I can see two attendees here who have helped me. So what the HFA would have given me is what, yeah, I
It's
suspect that
likely that
perhaps a cancel cycle may not
may
have
not have
been,
been
they
included.
may not have been included. But it's a very good point for when we're thinking in future what we may want to do. But certainly we haven't had in our own clinic we have a very few cancel. I can't even remember what we're canceling for. Virtually nothing. You know, if you go with the way we want to go, try and get the pregnancy first time. If not, ask yourself what can you do next time, and if not, we have to alter the whole game plan altogether. But thank
Lovely.
you very much, Uma.
Thank you, Gulam, very much. I'll pass on to Harish now to introduce Priya. Thank you, Harish.
Thank you, Uma. Thank you, Gulam, for an excellent talk on IUI. We'll continue with the same theme of on IUI. Gulam mentioned one thing, that natural IVF, which we all know, injecting the sperm inside the uterine cavity around ovulation, simply doesn't work. And he provided some evidence for some of the variations and modifications that have been done to IUI treatment, and also some evidence. And it is my great pleasure to welcome Dr. Priya Bide, who is an expert in this topic, to talk about various modifications that have been done in IUI and the evidence behind their use. And also, she'll also talk about various add-ons that have been used in IUI. We know that IVF add-ons have been controversial in the last decade. Similarly, IUI add-ons have been used, and Priya will talk about IUI add-ons as well. Most of us in the UK reproductive medicine, we know Dr. Priya Bide. She is a clinical reader in Queen Mary's University of London. She's also a senior clinician in reproductive medicine at Homerton Hospital or Homerton Fertility Centre, which is in London. She is the module convener for obstetrics and gynecology undergraduate teaching at Barts and London School of Medicine and Dentistry in London. She's an active researcher. She has been a principal and chief investigator for various national and international trials, and has published her studies in respected journals. She has supervised many various research degree students, and she sits on the reproductive medicine studies group of the Royal College of Obstetricians and Gynecology. She's also Cochrane member of the Cochrane Gynecology and Subfertility Group. There are so many more achievements of Priya, but I would not go into the detail. I would welcome Priya to give her next talk. Thank you, Priya.
Priya, you're muted.
Priya, you are on mute.
Apologize for that. Okay, so thank you so much, Harish, for your very kind words, and good afternoon, everyone. I would like to thank the Indian Fertility Society and also the IFS UK Forum for inviting me to give this talk today. And my topic for this afternoon's talk is to discuss the role of add-ons in IUI treatment. Add-ons is a phrase that has been quite extensively used in relation to IVF in the context of clinical practice and also for research. And more so in the United Kingdom, where our regulatory body, the HFEA, has actually set up a traffic light system to inform all the relevant stakeholders, including patients and healthcare professionals. Now, we also use add-ons in IUI, although they may not be formally called add-ons. And it seems that their use is fairly subjective and dependent on operator. They also seem to be used quite empirically, and they haven't been discussed as much as the IVF add-ons. So that's precisely what I'm going to do today. And before we start discussing the add-ons to IUI, I just briefly wanted to go through the indications for IUI. And this is relevant because the biological plausibility for a particular add-on may or may not be indication dependent. And also the other thing to consider is that the evidence that we have or the evidence that we present may or may not be indication specific. So the indications for IUI may be using donor sperm, and this is for same-sex couples and single women who may have fertility problems, but by and large is presumed not to have any fertility problems. IUI may be used for couples who are unable or find it difficult to have penetrative vaginal intercourse, and in very specific conditions where it may be used to help couples to achieve a safe pregnancy, for example, HIV discordant couples, or where the male has a genetic disorder that he does not wish to pass on to the child. Now, in my practice, all of these conditions where IUI may be considered a first-line treatment do not constitute the majority of the IUI that we perform. The majority of IUI that we perform is for unexplained infertility, mild male factor, or mild endometriosis. And the reason that I have put this indication in red is that in the UK, we are governed by the NICE guidelines, and the latest NICE guidelines, which I would say are not very latest, because I think the new ones are due to come in anytime soon, specifically say that IUI should not be performed for these indications, and patients should be counseled to move straight on to IVF. Now, considering that there is a U-turn on this, and in 2023, the ESHRE published their new guidelines, which say that in couples who are at a poor prognosis for natural conception, IUI should be offered before proceeding to IVF. So it looks like that we might be doing more IUI in the future. So if we are talking about more IUI, how much IUI are we doing right now? So this is the data for the UK. Now, in the UK, the HFPA will report in their national statistics annually, mostly for donor cycles. And this is the latest report from the HFPA for 24, which said that in the UK, we performed about 6,000 donor IUI treatments in 2022. They don't normally come out with the IUI performed with partner sperm, but this information is available, and it was published in a paper in 2020 by Dr. Badur. And it said that over a period of 5 years, in the UK, we performed about 30,000 IUI cycles using partner sperm, which averages to about the same as 6,000 cycles a year. So we're doing about the same amount of partner and donor IUI in the UK. Let's look at what happens in Europe, and this is data from the European registries. And of course, the size of Europe is much bigger than that of the UK, but what I want you to see is that the amount of husband or partner IUI that they are doing is almost 3 times that of donor IUI. So they are doing a lot more of partner IUI in Europe, and I'm sure that is also the case elsewhere in the world, and also probably in India. So if we are doing so much IUI, the next question is, how effective is IUI? And again, I would like to share some data from the UK. And this is from the HFA registers again. Give me a minute. Yeah. The HFA live birth is at about 11 to 12%. Whereas the ESHRE live birth is at about 8%. And this is registry data. So this talks about real life scenarios and effectiveness. There is also some data from the trials that contributed to the ESHRE guidelines, and these are much higher success rates. And as we know, that results from trials are always higher because entering a research trial itself improves the success rate whether or not you are in the intervention arm. But the registry data is kind of more reflective of what real life practice looks like. And this is, again, donor data, and we are averaging at about 12% on ESHRE and HFEA data, whether it's stimulated or unstimulated cycles. So if we say that this is the kind of success rate that we are looking at, and we are looking to do more IUI, then we need to think about how we can improve the success rate of IUI. And then I would break it down into 3 factors. What does the effectiveness of IUI depend upon? There are patient-related factors, some of which are not modifiable, like age, and some things that may be modified, like your lifestyle, smoking, body mass index. These can be improved. There are a lot of sperm-related factors to which Dr. Ghulam has talked about, and this regards sperm concentrations, laboratory methods of sperm preparation, And then there are factors related to the actual IUI procedure itself, is what I'm going to talk about today. So once we have made a decision that we are going to do IUI, for whatever indication it might be, can we improve the success rate of this procedure? Can we deliver on higher success rate? So for the process of simplification, you could consider the IUI cycle in 3 parts. One is the clinical cycle preparation, and that has to do with the female partner. Then we have the sperm preparation, which Dr. Ghulam has spoken about. And then the actual IUI procedure itself, where we are going to inseminate the sperm into the uterine cavity. So for the purposes of simplicity, I have broken down the IUI cycle into 4 phases. And the first being the follicular phase. The follicular phase starts from the beginning of the period or the beginning of the cycle up to the point of the LH surge. The second phase is from the LH surge to the point where we perform the IUI. The third is the IUI procedure itself. And then comes the luteal phase after the IUI is performed. Now, if you consider what might be the simplest or the most basic type of IUI that one might perform, and that might be a natural cycle IUI, where there are no medications in the follicular phase, you allow the patient to have a spontaneous LH surge and do a single blind IUI procedure, blind in the sense not ultrasound controlled, and then the luteal phase has no support or no medications. So this is the standard or the most simple IUI procedure. Now, I'm going to talk about variations and add-ons. And just to clarify, a variation is something that one would normally do, but you could do it in different ways. And the 3 variations that I'm going to talk about today is, one is what type of catheter should you use, firm versus soft, whether the patient should have an empty bladder or a full bladder, and then should the sperm be released as a bolus is what is mostly standard practice, or should there be a slow release of sperm? Now, an add-on is something that you need not do, which is not always done and is done as an extra. And the add-ons may be added on to any of the 4 phases of this cycle. In the follicular or even before the follicular phase, one might do an endometrial scratch, ovarian stimulation, and ultrasound monitoring, and this is more relevant in the context of natural cycle IUIs. Do we allow the patient to have a natural LH surge, or do we give a trigger? Do we perform IUI and ultrasound guidance, or can we do a blind IUI? Do we do single insemination or double? And what is the role of luteal phase support? So our group did a fair amount of work on this topic, some of which is published. And this was a paper that we published in 2024. And it has a lot of comparisons on the add-ons. There is some work which is unpublished, and that's done by medical students as a part of their curriculum. And there is still some more work which is en route to getting published. So let's start on with the first variation. Does the type of catheter actually matter? And the forest plot on the top left-hand side tells us the live birth rate, and there were only 3 studies. And that showed that the type of catheter did not make a difference to live birth rate and is same for the clinical pregnancy rate, which is the forest plot at the bottom. And this was from the Cochrane reviews from 2010. We did an updated search, and we didn't find any new studies. The graph on the right-hand side tells you about the risk of bias, and I put that there specifically because except for blinding, which cannot be avoided in this type of trial, most of the studies seem to be of fairly good quality. And what it says is that there is no specific conclusion that can be made regarding the superiority of one type of catheter over the other. So what should your practice actually follow? And as a good practice point, I would say that the best thing to do is to use the catheter which suits the operator. On one hand, one might say that a soft catheter is good because it reduces the incidence of uterine cramping. But then if your internal os is slightly stenosed, or if there is a very difficult angle at the junction of the internal os, then a soft catheter may not be able to negotiate that curve, in which case a firm catheter might actually help you to do a much easier IUI. So in terms of actual live birth rates, there is no difference, but it is good to use a catheter which actually suits your own practice. Moving on to bolus insemination versus slow insemination. Now, we did a systematic review on this, and we found only 2 studies. One of the studies was very, very old. It was done in 1992 and had very few patients, but the newer study is done in 2020. And I actually remember this study because we recruited for this study at the Homerton Hospital. And what they did was they put in a self-retaining catheter into the uterus and attached it to a syringe which was strapped to the thigh of the woman and then sent her home. And the sperm was released over a couple of hours, after which the woman would deflate the self-releasing, the balloon of the catheter, remove the catheter and discard it. Now, this showed that there was no difference in the 2 arms, and therefore current evidence doesn't show any benefit of a slow release preparation. But there is more to it than just the pregnancy rate. We got feedback from our patients that they actually didn't like this. They felt quite uncomfortable to take this self-retaining catheter home. They were not sure whether they would be able to remove it properly. There was also a fair amount of reluctance from our staff to send patients home with an indwelling catheter because you're not sure at what the end point of this is going to be. So based on all this, I would not recommend to have a slow release sperm. At the same time, when we do a bolus insemination, it's not like we want to jet wash the uterus because we don't want that sperm going in too fast. So although it is a bolus, I would be careful about the speed at which we are inserting the sperm because you don't want to push it in very fast. Okay, what about full bladder and empty bladder? There was just one single randomized control trial, which is not adequate to give you a guideline. It showed that the incidence of a difficult IUI was much higher in the empty bladder, and the pregnancy rates were higher. And as a common sense or good practice point, I would kind of advise to say that it is sensible to ask for a half full or a full bladder, which is very similar to embryo transfer procedures, because this is likely to make your IUI much simpler, and a simpler IUI, less traumatic IUI, is likely to improve your success rate. Okay, moving on to endometrial scratch. This is interesting. Endometrial scratch is talked a lot about in the context of IVF. People also do this before IUI. Now, this forest plot is from the Cochrane review of 2021, and it shows that there is no significant improvement following endometrial scratch for IUI. We did a much more recent review, and this was published in 2024. And what you can see here is that both for live birth rate and for clinical pregnancy rate, an endometrial scratch actually improves the odds of actually achieving a live birth or a clinical pregnancy, with the confidence interval not crossing 1. The diamond lies clearly on the right side of 1. The lines that are on either side of your diamond are the prediction intervals, and that's something extra which is added on by our statistician. So that is not actually your 95% confidence interval. So are we now advising that women having IUI should have a scratch? And my answer to that is no, because although the point estimate and the confidence intervals show that this may be effective, the quality of the research that inputted into this systematic review was considered to be of low or very low quality. So it was downgraded on several grounds for a high risk of bias, imprecision, and also for inadequate numbers. So I'm not saying that this result doesn't mean anything, but it has to be taken in context to say that we have to consider what is the quality of the research. I would not discount endometrial scratch, but would say that actually we need to do a good, robust study which will give us the right answer. Moving on to ovarian stimulation, and there was a Cochrane review in 2021, and it says, and we all actually follow this, to say that gonadotropins are better, and they improve cumulative live birth rate. And if you compare them to Clomid, they are much, much better. It also says that there does not seem to be much of a role for different combined therapies for addition of GnRH agonists or antagonists to IUI programs. In my opinion, IUI is supposed to be a simple treatment, and I think it should be kept simple. So IUI is not IVF, and you don't really want to add on so many medications that brings it close to IVF. It is simple, and it should stay simple. We did a much more recent systematic review, and what we did is we did a network meta-analysis to see what are the different types of stimulations that are offered for IUI. And each of the nodes here tells us the number of studies, and the bars tell you what the comparisons are. So we had very few comparisons between, so injection is gonadotropins. Only 2 studies which actually compared gonadotropins with no stimulation, but the majority of the work that was done compared gonadotropins and Clomid or Clomid and letrozole. And what did we find? This is quite a complicated chart, but I just want you to focus on a few things. There are several columns, and the relative effect is of the column versus the row. So what you can see is that gonadotropins compared to Clomid, and that's the number 1.58. So gonadotropins are significantly better than Clomid. And if the ones in the bold are the significant figures, what we can also see is gonadotropins plus letrozole seems to be significantly better than a lot of comparisons, like letrozole alone, Clomid alone, or no stimulation at all. This was unfortunately only one study, so the strength of the evidence is not very good. But by and large, we see that gonadotropin seems to be a very good option and has much better success rates than Clomid. And this is something quite similar. And these are the SUCRA figures. SUCRA is the surface under the cumulative ranking. So to put it in layman's terms, if we were to have several interventions and they were all to run a race several times, then what is the intervention that comes first the maximum number of times? And these are the graphs. And this shows again that gonadotropins here is much, much better than Clomid or no stimulation or letrozole by itself. The combination studies, which is gonadotropins plus Clomid, gonadotropins plus letrozole, have very good SUCRA rankings, but the number of studies that have contributed to this is less, and hence that should be taken into consideration. So gonadotropins are a good way to improve success rates. Okay, so if we are doing, and this is a very interesting question. If we are doing a natural cycle IUI, do we need to scan these women in the follicular phase? Can we not just say to them that call us when you have a positive LH surge and we will time the IUI the next day? And this is more so important in terms of economics or planning of your IVF clinic rather than success rates. And we tried to find an answer to this, and we actually did not find any randomized control trial. In our clinic, we do routinely scan people in spite of a natural cycle, but I'll be interested to hear if there's anyone who actually doesn't, because this is something that your clinic might want to consider if you have good backup data of success rates to say that you don't need to call people again and again, just do the IUI when they actually have a surge. Okay, does the use of trigger improve the success rate? In terms of success rate, current evidence doesn't actually support using a trigger, but a lot of clinics will use trigger, and this is for 2 purposes. One is to schedule the IVF, one is to schedule the IUI cycles, and then the second is, again, the Sunday working service. So if your clinic doesn't have a 7-day service, then a trigger might actually be quite useful, because if you see an 18mm follicle on a Friday morning, it might be worthwhile to trigger and do the IUI on Saturday rather than the patient missing the whole cycle because your service is not open on Sundays. But in terms of pregnancy rate, it shows that there is actually no difference. What about ultrasound guided IUI? And this is very similar to the trigger, that in terms of success rates, there doesn't seem to be much evidence for an ultrasound-guided IUI. But again, this may be useful for improving the confidence of your staff and also for giving some peace of mind to your patient. If you have resources for a scan machine, if you have somebody who is a second operator and can hold the scanner on the abdomen, then it allows your operator to do an ultrasound-guided IUI and place the catheter correctly into the uterus. And if the patient can see that, then maybe they feel a bit reassured that you've done the IUI in the right way. Double insemination doesn't seem to show any benefit for improving live birth rate, and that is again the Cochrane review from 2021. Now, this forest plot actually breaks up the evidence in terms of the indication. So neither of the categories show any difference. The other indications was a single study. It does show that the diameter is slightly to the right of the center line. Again, the confidence intervals do cross 1, but this is a single study. It has got very small numbers. And as you can see, there is some reds in the risk of bias. So double insemination, if you have got your stimulation right, if you have got your timings right, then I don't see the role for actually having to do the IUI procedure twice, because it's going to increase your cost with no value added in terms of success rate. And bed rest as well. Bed rest, only 2 studies, but absolutely no difference in live birth rate. Okay, this is one of the slides that I really like, and this is the role of progesterone. And we did this meta-analysis, and we have the forest plots for live birth and for clinical pregnancy. And what I want you to see is that we have sorry, I can't see my screen. Yeah, we can see that we have the point estimate at 1.37 for live birth rate with a confidence intervals that does not cross 1, and the same for clinical pregnancy rates. If you look at the prediction intervals, which are the bracket below, which tells us that if you actually did a study in the future, where would your data point lie? That lies very close to 1 for live birth and actually does not even cross 1 for clinical pregnancy. We did a grade for the quality of evidence, and we found that there was moderate quality evidence for the use of luteal phase progesterone. Now, a little bit more about the studies here is to say that all the studies included in this meta-analysis were actually stimulated cycles using gonadotropins, and all of them used the trigger. The progesterone was all vaginal, and the dose was very variable. It was variable somewhere between 200 to 800 milligrams, and it was either in the form of pessaries or gel. So there is a good evidence to say that it actually works, but we need to work a little bit more about what preparations should be used and what the dose should be. This is a summary of all the add-ons. And as you can see that if you try to see what is effective and also has moderate quality evidence, then luteal phase progesterone stands out amongst all the add-ons that we have discussed today. That is just a summary to say that we did not find any evidence for hydrotubation, double IUI, tocolytics, oxytocin, misoprostol, or bed rest in terms of live birth rates. Trigger and ultrasound guidance don't improve the success rate, but if it helps the administrative workup of your clinic and it helps in cycle scheduling, then it may be used. The interventions that did show a positive effect were the endometrial scratch, ovarian stimulation, and progesterone. Scratch has low quality of evidence. Further research is needed. Progesterone had moderate quality evidence, but there is still some work needed in order to finalize what the dose should be and how it should be administered. I hope that has actually helped you. Thank you for listening, and I am happy to take questions.
Thank you, Priya. Thank you so much for that excellent talk. We've got a few questions here, but given the time, I'll ask a couple of them. First question is from Ghulam Bahadur. So Ghulam asked this question. You mentioned about those who entering the trial end up having better results. How do you explain this?
This is quite widely published, not only in the context of IUI, but in the context of any clinical trial. And this is the paper that I saw last was published in the British Journal. And it said that whether or not a participant is in the intervention arm or the control arm, irrespective of what your intervention might be, it may be IUI, obstetrics, gynecology, surgery, it could be anything. I think it is just the patient care that matters, because it gives a more personalized care, it gives a more individualized care. And that may be the reason that even patients in the control arm tend to show much higher success rates than what you see in real life scenarios. The other reason may be that it is possible that trials have more restrictive inclusion criteria, and it may be possible that some trials are actually including only good prognosis patients. So a pragmatic trial will include everybody and have much wider inclusion criteria. And those are the trials that will bring the success rates close to what a real life scenario is. If your inclusion criteria are restrictive, you're picking up good prognosis patients, it is going to differ. I hope that answers your question, Ghulam.
Most of the trials are done in research active centers who have strict kind of evidence-based medicine. Probably that helps in the success rate for these patients as well. Priya, the next question is from Dr. Lakshmi Singh Shetty. She asked this question about the blood at the tip of the IUI catheter. Does it make a difference, similar to embryo transfer, IVF success rates?
I don't have data to back up the question, but from my personal practice, I would say that a small amount of blood, I would not think it is very detrimental to the success rate. Of course, you don't want something where there is a lot of blood oozing out like you're performing some kind of surgery, which was definitely tell you that you have actually caused significant trauma to the endometrium. But a small amount of blood at the tip of the catheter, in my personal experience, has not significantly changed success rates. I think it's the quality of the eggs and the sperm that matter at the end of the day.
Fatima Hussein asked this question about multiple pregnancy rate. Do you have any data with regards to stimulated IUI versus natural cycle IUI?
Yeah, so the network meta-analysis that I presented, that's not published still, and we are still awaiting the network on the multiple pregnancy rate. But what we are seeing is that the multiple pregnancy rate is very closely linked to the number of follicles and the cancellation policies that clinics have had in place. So if there is no cancellation policy, the number of follicles is allowed to be 4, 5, or any number possible, then your success rate is going to be much higher, but with it comes a higher multiple pregnancy rate. I don't have the data to tell you right now, but in the context of multiple pregnancy, I think it is just a balance to say that you have to have a cancellation policy, and whatever success, so it is a balance between increasing your success rate and balancing your multiples. And where that cutoff comes is clinic dependent. I would say that in the UK, we are currently at more than 3 follicles should be cancelled, because your success rate is going to be higher if you have more follicles, no doubt about it. But is your system equipped to deal with all those multiples, and is it even worthwhile to increase your success rate for your multiples? That's the question.
Thank you. Next one from Raj Mathur is asking about how important it is in terms of timing in a natural cycle IUI with spontaneous LH surge, in terms of making sure that we get the time right.
That's a question that comes up time and again. And I think this natural LH surge and IUI has been much discussed. So so there are a couple of things. Is that an LH surge will appear approximately 12 hours after the trigger, or if there's no trigger after the start of the LH surge, it will appear in the urine. The LH peak, in my opinion, is quite narrow. So it also depends on how frequently you ask your patient to do the LH test. So if it's done twice a day, I think that would be optimal. Because if a patient says she had a positive LH surge at 8 o'clock in the morning, she might have actually also had that LH surge at 6 o'clock the previous evening. So
Cool.
I think that the IUI should be done 24 hours, within 24 hours of the LH surge, because that's the lifespan of the oocyte. But I think that the LH testing should be done twice a day, because it might be too late if it's done only once a day. So if it's positive one day morning, then you might have just missed it if it was before. And maybe I think this is a question I would like to ask Gulam, and I have never found the answer to this. To say that we know that once the sperm is deposited in the vagina, it is available, or it's there for maybe 72 hours or even later. But if we are putting sperm directly into the uterus, as we do in IUI, then how long does it stay in the female reproductive tract? So is an IUI too early? I don't know the answer to this. We do not have a lower limit for doing the IUI, but we say that after LH surge, we do it at up to 24 hours. I tried to look at the literature on this, and I found only 3 RCTs, and they all said different things. So there is no consensus on this, really.
Maybe we should have a debate on this in a future webinar. I'll leave it for now. There are a few more questions, Priya. If you don't mind answering them in the chat box, if you don't mind.
I will.
And I'll now hand over, and thank you so much again for your excellent talk. I'll hand
Thank
over
you so
back
much.
to Dr. Uma Gordon now for the final talk.
Thanks.
Thank you, Harish. It's my pleasure now to introduce Dr. Priya Bhave Chittavar. Priya is consultant and head Department of Reproductive Medicine, Bansal Hospital, Bhopal. She is F&B reproductive medicine teacher. She is FOGC recognized trainer in basic and advanced infertility management courses. She is also a Cochrane reviewer and author. She has been awarded the Dr. Pankaj Talwar Gold Medal at IFS in 2022. What was also amazing is that she's an Ironman triathlete. Incredible, and hoping to catch up with you on that in December. Fertivision, Priya. So looking forward to your talk on management of PCOS-related infertility, an Indian perspective. Thank you.
Thank you. Thank you so much, Uma. I would like to extend my sincere thanks to the entire IFS family. It is really a proud moment for all of us here. Growing up, I always wanted to train in the UK, but somehow that did not come, that did not happen. And I remember reading Dr. Priya and everybody's studies very, very keenly. And it's such an honor to be here in this webinar today. So the topic back to basics, I think, is very, very pertinent in today's scenario, because we now in India have a very large number of trainees who are coming into reproductive medicine. The new regulation states that the person has to work for 3 years in reproductive medicine before they can go on and do an independent practice as a fertility specialist. And so it's very important that these kind of webinars focus on the basic things like IUI optimizing outcome. And I would like to really congratulate the previous two speakers on very lucid and very important presentations. So when we talk about management, we definitely talk about treatment, but we cannot overlook the diagnostic aspect. So in my presentation, this will be the flow. I'll talk about the prevalence of PCOS in India, the phenotypes and the distribution of phenotypes that we see, the diagnostic criteria and the metabolic risk, because often as fertility specialists, we focus so much on giving the couple a baby, a pregnancy, that we forget that our target is a healthy mother and a healthy baby at the end of it, and we often overlook the metabolic risks that come with PCOS. I'll talk about the Indian data on treatment of subfertility, and finally, because the data from India is patchy at certain places, we have to rely on the international guideline by the PCOS network, and I'll briefly take the audience through the latest 2023 guidelines. When we talk of prevalence, all of us know that India is not one country. It is probably several different countries. Every 10 kilometers, the language changes, everything changes. So no wonder the prevalence of PCOS also in all these different studies is very, very different. It's 4% in some studies. Using the same criteria, it is as high as 35 to 40% in others. And so this recent meta-analysis attempts to put everything together, and what they found is it's as expected, it's very heterogeneous. They use the random effects model, but you can see that it's all over the place. And the pooled prevalence is somewhere around 11%, but most of the studies show such a wide variation that if we try and see the couple of studies which contribute most to the heterogeneity, almost 96%. But if we try and explain the heterogeneity, why is the data so heterogeneous? Why does the prevalence vary so much when the Rotterdam criteria has been set and it's very, very clear? It's probably because these studies, many of them also look at adolescents. And now with the recent revision in the 2023 guidelines, we know that we cannot rely on the Rotterdam criteria conventional for adolescents, and ultrasound should not be taken into account for them. Also, maybe there is a regional and ethnic difference in how we are metabolically and also from the reproductive point of view. Another aspect also is the hirsutism scoring. Some studies looked at a cutoff of 6, others looked at 8. And the one big contention which I have with most studies is that the follicle number per ovary, which is set at 12 by the original Rotterdam criteria and is now proposed to be 20, was different in all the studies. So probably that could account for some of the heterogeneity, but I think most of it is because of a difference in the socio-economic status also, because as you look at more women in the middle class, you'll find more of PCOS. Higher income groups, somehow because they have more access to exercise and better diet, actually in the higher income group of late we see less patients with PCOS. Also, there's a regional difference. So more studies from the south, and the more studies you take from the south, the higher is the prevalence. Now we all know about these 4 phenotypes, but what are the Indian phenotypes? What is the most common phenotype that we are likely to encounter when we talk about India? Dr. Sujata Kar is a very active researcher in PCOS, and she's done many studies. And this study, she has looked at the various phenotypes, and she's compared the phenotypes with respect to the prevalence of the metabolic syndrome. And these are the definitions that she's used. And what she's found is that in her study, which comes from Bhubaneswar, the largest group was women with all 3 characteristics, 65%, followed by women who are not hyperandrogenic but are anovulatory. If you ask me, I'm sitting in central India in a place called Bhopal, and practically we see very less hyperandrogenemia, whether it is clinical or biochemical. So in my own practice, it's not published yet, but almost 60% of the women or more than that are P and O, that is anovulatory PCON. What is shocking is the overall prevalence of metabolic syndrome was 35%. So this means that we really have to be looking more closely at the metabolic parameters and screening all women. And when it comes to women who do not have hyperandrogenism, the prevalence of metabolic syndrome is actually quite less. It's just 10%. Now, this study conducted in CMC Vellore, this is back in the times when I was doing my fellowship, and Dr. Kavita, the first author, was my fellowship batchmate. What she did is she's taken 120 odd women with PCOS who presented or for infertility and looked at the risk factors for metabolic syndrome. What we found is that the 2 factors, almost a similar prevalence of metabolic syndrome even in the south. So we saw that in the Bhubaneswar study, it was 35%. In Vellore, it was 37.5%. And which are the women who are more likely to have metabolic syndrome? It is older women, that is women more than 25, and women who have central obesity. Central obesity is something which is very, very prevalent when we look at women with PCOS down south. When we go up north, it is hirsutism and hyperandrogenism, which is more frequent. Of course, central obesity too, but it is much more common in the south. So this is how we had defined metabolic syndrome. And if you look at the significant findings, higher the age, more the weight, more the BMI, and higher the waist hip ratio, it was more significantly correlated. And when you run a logistic regression, we found two factors which are very significant: age and waist hip ratio. So all the women who have a waist hip ratio more than 0.85, in the Indian context, it's very easy to measure, does not require anything other than a tape and a person who is dedicated to do it. We should be screening at least these women for metabolic syndrome. Another thing which has come up in the recent PCOS guideline is the AMH cutoffs and the use of AMH for diagnosis. This study again from India by Dr. Nalini Mahajan says that the cutoff of 5 nanogram per ml could be a reasonable cutoff for diagnosing PCOS. The numbers in their study were small, but probably we all need to collate our data in different regions and look at it. All of us know that now all of us use FNPO of 20. Rotterdam put it at 12. Now, this is a very, very interesting study because although it's a small study, again from Dr. Sujata Center in Bhubaneswar, she has used the best machine there is, that is the Voluson E8, a high frequency probe, and she looked at the follicle number per ovary for diagnosis of PCOS. Now, what she found is that the cutoff for follicle number per ovary in Indian PCOS women is 12, not 20, as most of the other studies would have us to believe. The cutoff for ovarian volume is 6.15 centimeter cube and not 10. So this is a single study, a small study, but I think it gives us so many ideas for future studies which can actually be done not with great difficulty. And look at all the other studies. It was this study from USA, Lujan et al. And Diwali et al., which actually led all of us to increase the FNPO. What she concluded was that at the same age, compared to a Caucasian woman, an Indian woman has a lower ovarian reserve. So that is what she says, that there appears to be an ethnic difference when it comes to the follicle number per ovary, and Asian women have a lower FNPO compared to Caucasian women. Now coming to the Indian data on the treatments, we all know now that letrozole is the first line. But for a very long time, unjustifiably so, as Indian doctors, we were deprived of letrozole. Letrozole was banned in India in 2011, and the ban was revoked only in December 2017. It is quite surprising because as this was being banned, this was a study which was published close to the time when it was being banned. It is from AIMS by Dr. Kallol Roy. It's a very good RCT on letrozole and clomiphene. And not surprisingly, it's a very well conducted study. They did not look at per cycle, but they looked at per patient data, and a significantly higher live birth rate of 40% with letrozole compared to 21%. Despite the publication of this study in 2012, we had to wait for another 5 years to get letrozole back in our clinics. So this is probably a lesson that policy often does not keep up with the evidence which is generated in their own backyard. So this was the time where the study by again Dr. Sujata was published regarding clomiphene metformin or clomiphene and metformin. This is the time when we did not have letrozole, and her conclusions echo the same conclusion as Tang et al., the famous Cochrane review that we often refer to, that when you add CC to metformin, the ovulation rate is maybe more, but the live birth rate is similar. Now, she also found that almost 47.5% of the Indian women were resistant to PCOS. They did not respond to 150. And that is all the more reason why letrozole has been embraced so much, because most of these women will end up actually ovulating with letrozole. And I don't remember doing ovarian drilling in the last 4 years, 3 years, that we've gotten letrozole back. Now, coming back and briefly outlining the recent International PCOS Network guidelines, first published in 2018. I do this with the realization that in India, we have a huge number of PCOS, and we could have actually much more data, not only on the prevalence, but also on the treatment and the metabolic outcomes. But I think that is a job for all of us to take up. We will go through the recommendations from the 2023 International Evidence-Based Guideline with a little regret that China and India, probably the two countries that represent most of the cases of PCOS in the world, do not find a representation, probably because there are not enough studies and not enough people to take the lead in writing this guideline. So there are three types of recommendations: evidence-based recommendations, clinical consensus recommendations, and clinical practice points. What is very important for all of us, at least in India, where we run very busy OPDs, it's not very uncommon for all of us to see 50 to 100 patients in a day. And we are very focused on the outcome that is of interest to patient, that is give them a pregnancy as fast as possible. But we forget that the first intervention always has to be diet and exercise. Even in lean PCOS, the woman would benefit from resistance training and certain modifications in diet. And luckily, the guideline clearly mentions the amount of exercise and the way in which she has to model her diet. That is, she has to have an energy deficit of 30% or give up maybe one meal in the 3 meals that she has. And it's very important for all of us to emphasize that the woman should not fall prey to the fad diets that are all over the internet about PCOS. Now, there's very, very clear evidence on letrozole. And thankfully, because of that, laparoscopic ovarian drilling is almost out in most of our clinics. Where letrozole is not available, I think the countries are very less, we have it available, and it has a much lower risk of multiple pregnancy. When it comes to CC and metformin, the women who are insulin resistant or who have over diabetes are good candidates for metformin. But for ovulation induction, clomiphene is definitely better to metformin. Now, coming to the data on gonadotrophins, unfortunately, I could not find good Indian studies on use of gonadotrophins in our context, because in our context, the availability not only of the drug, but the affordability and also the availability of personnel who are able to monitor gonadotrophin cycles may be a problem in many areas. So gonadotrophins actually are probably third line for all of us, and they could be considered as first line in women wherein ultrasound monitoring and expertise to monitor them is available. But I think the good practice point is that we have to absolutely consider the cost, availability, and the risks of multiple pregnancy, which are much more in India because all the expenses for a neonatal admission are borne out of pocket by the patients with very little insurance or government help. Something which is coming up is surgery for PCOS, bariatric surgery. We see more and more women who come and ask us that, you're asking me to lose so much weight and I can't do that. Can I go in for a sleeve gastrectomy? Can I swallow a balloon? Can I undergo an endoscopic sleeve? So practically, it actually could be a second line therapy for women who are clomiphene citrate resistant and who have morbid obesity with risk factors. For IVF, the guideline is very, very clear. It has to be an antagonist protocol and preferably with a luprite trigger. And HCG, as far as possible, should either be avoided or used with a low dose. There's no role of adding LH, and you can use a recombinant or a urinary drug. So this practically summarizes the guideline on PCOS, which is very recent and which all of us who are practicing should know and should adhere to. But I think there is a massive scope, at least when it comes to our country. I think all of us can at least start evaluating the data for the cutoff for follicle number per ovary, because this data is available to all of us. It is accessible. AMH cutoffs for PCOS, again, it's not a problem because we run this test for most of our patients. Metabolic data and pregnancy complications. And I see a huge scope for a collaborative study with the UK forum. With your guidance, maybe we'll be able to come up with really meaningful data. Thank you so much.
Thank you so much, Priya, for going through the evidence so clearly. Thank you. We have a question from Raj Mathur here. He's saying that, is it feasible? Let me just get the screen again. Do you think it is feasible for weight loss and exercise to be the first line of treatment in PCOS patients in fertility in India? And do you believe there should be a BMI or waist circumference cutoff above which we shouldn't be doing IVF? So let's go to the first one first. Do you think there should be weight loss and exercise? Is it feasible in India to do this?
I think it's absolutely feasible. The only thing is that we should not deny and turn them back, because they come to us with a lot of hope and they're very likely to drop your clinic if you tell them to go back. So sometimes what we do is we just give them a little bit of metformin, call them for follicular scans, and also monitor the weight and how they're doing on their journey. So it's absolutely feasible. It just takes a little more time. And in fact, interestingly, what set me on my Ironman journey is one of my PCOS patient whom I was advising her to lose weight, and she just looked at me and she said that it appears that you've also gained some weight since I last saw you 7 years ago.
That's very interesting, but that's a very valid point. We can't just send them away. You need to support them. And ideally, if you have a way of offering counseling or offering some sort of a weight loss management, it would be helpful, I think, for these patients, because they can easily get very low with this weight scenario. And the second point, do you think there should be a BMI cutoff or a weight circumference cutoff before you offer treatment for these women?
I really don't think so. I think there's some women in India, especially certain ethnic groups, who are built big and they are metabolically absolutely normal. And there's some women who are actually, it's called lean outside but fat inside. So there's some women who are actually very lean but have metabolic derangement. So I think BMI or waist hip ratio is only a part of the story. And probably when we do more and more of body composition analysis with better techniques like DEXA, we'll actually come to know the extent of the visceral fat that they have. So I actually don't agree with any cutoffs, be it AMH cutoffs, weight cutoffs. I think nobody should be excluded from fertility treatment. That is being very judgmental. And I really think that there are some women in India, certain races who are actually built big and they're actually healthy with no metabolic issues. So we should not turn them away, trying to fit all women in certain boxes.
I suppose the concern is the risks during pregnancy, etc., with a certain BMI.
Metabolic assessment and anybody
What
who's morbidly
specific
obese.
aspects would you assess, Priya? Because you did say that we need to assess them for metabolic aspects, and you quoted quite a high metabolic incidence. So what specific tests would you be recommending then to assess for the metabolic
So as per the NCP ATP3 criteria, we have to check for waist hip ratio, fasting blood glucose, lipid profile, specifically triglycerides and HDL, and blood pressure.
Lovely, thank you so much. Shantanu makes a comment, Dr. Shantanu Acharya, that with the LOSI trial, we should be able to get some answers with the uncertainty between Clomid, letrozole, metformin. But for the Indian population, it may be different. Because I do some work in India, Priya, I really take your point about ethnic differences. Because I think although the normal BMI according to the Western category is 20 to 25, let's say, you may find that with the Indian population, even a BMI of 27 may be equivalent to 32 here. So to get parameters that are relevant to the specific population is very, very important, like the ones you've quoted for ovarian volume, as well as in terms of the number of follicles. There's another question here. Do people use GLP agonists for PCOS?
I think every third patient who walks in our clinic now wants Ozempic, but we don't prescribe it right now. We do send them to the endocrinologist if they are very interested, but because of the cost and because it's a new drug, we're not prescribing it very much, but we do have a lot of interest from the patients about this.
Okay, so that was the question from Saumi, I think. And we have one from Kamal Ojha. why is the AMC and AMH and AFC low in the Indian population, as has been documented in studies now? Why is it low?
So I think there was only one study which was a collaborative effort between Spain and India, and it was a retrospective study. So I think it's too early to actually conclude that it's low. But I think we need to think about it and maybe analyze it a little more.
Again, with different areas, the pollution, working in factories, garment factories, many of them do, sometimes in agriculture. So I think there needs to be a lot of bringing in of occupation, etc., if you're going to come out with an answer for that, I think. So I think that has been a great session. I'm just saying thank you to you, Priya, for that very good talk and getting an Indian perspective to all of us. Can I ask Raj to kindly close the session, please? Thank you, Raj.
With pleasure, Uma. And I've had such an enjoyable 1.5 hours, maybe slightly more than 1.5 hours. We have overshot our time very slightly, but it has been incredibly enjoyable, very informative. Thank you so much. This is a genuinely unique event that we've had as our inaugural webinar. I am so pleased that we've actually had speakers both from the UK and from India. And we've covered a range of perspectives. And what I'm delighted about is that we have not gone into high-tech IVF. We've not gone into the genetics of this or the chromosomes of that, but we've covered really important clinical topics that affect your patients, my patients, all our patients. I am so pleased. Thank you all to the speakers for presenting. Thank you so much to the participants who have asked really good searching questions. And I'm hopeful we'll have many more of these. So thank you all. And with that, we bring today's meeting to a close.